Welcome to PharmacyToDose, the Critical Care Podcast, a partner of the ACCP Critical Care PRN and a member of the Pharmacy Podcast Network. And I'm your host, Nick Peters. Wherever you are and however you are listening, thank you. Now, this is the Trial of the Week, where I review a landmark trial that was published this month in medical history. And phenobarbital in alcohol withdrawal is a very hot topic right now. And there's one prospective trial that is frequently referenced, published in 2013 in the Journal of Emergency Medicine. We're highlighting the phenobarbital for acute alcohol withdrawal syndrome with pharmacist author Joseph Lamb. So we set the scene with Joe. We talk about what the treatment of alcohol withdrawal syndrome was like prior to this study, Joe's role in the study itself. He takes us behind the scenes, which is really cool. Then we go into the details. We review our trial of the week, talk about pertinent findings, things they might have done differently now, and then closing with where are we now? How did this trial ultimately change what we do? And then what research do we still need to know on this topic of phenobarbital in alcohol withdrawal? So let's get going with our first September 2023 trial of the week. And very thankful to be joined by our guest today, Joe Lamb. Now, Joe is a critical care clinical pharmacist at Highland Hospital in Oakland, California. Thanks so much for taking time out of your day. Joe, how are you?
Oh, I'm fine. Thank you. Thanks for having me here.
Yeah, I'm really excited. You know, I mentioned in the intro, this is such a hot topic. It's cool to talk to someone who's on one of the biggest, most robust studies into this. So I want to kind of set the scene with us here. So in the years leading up to this trial, right, which would be that 2007 to 2009 timeframe, how did we typically treat alcohol withdrawal, right? Was barbiturate therapy routinely part of the treatment algorithm at that point?
So the benzodiazepine has been the first-line therapy to treat alcohol withdrawal. So, a lot of providers use diazepam, lorazepam to treat alcohol withdrawal. And then around that time, there were like a couple preliminary studies. There's some efficacy of phenobarb. And in our hospital, before our study, we used the phenobarb in more like a symptom-guided way. And usually we use like a small bolus of like 65 milligram or 130 milligram.
So you mentioned that there was like some small data, but prior to this study, was there any, prospective or other randomized trials that were looking at the use of barbiturates or specifically phenobarbital in alcohol withdrawal?
So prior to our study, there were not mostly case reports and then retrospective analysis. There was one randomized study, but it was not like blinded too. So our study is, it was like the first one, like prospective, randomized, double blind, producing some high quality evidence for the use of phenobarb for alcohol withdrawal. So before our study, there was like a couple notable ones kind of inspired ours. So, and there was one like a prospective core trial of like 62 patients. In that study, the patients were using phenobarb 260 milligram IV up to a mean loading dose of something like 598 milligrams. And then there was a randomized but non-blinded trial of like 37 patients. In that study, they were comparing the sodium valproic versus the phenobarb. And then there was a retrospective cohort trial for like 54 patients. Those patients were using diazepam and then an escalating dose of phenobarb, like in 65 milligram and then 130 milligram and then 260 milligram, and to see whether the phenobarb can reduce the need for mechanical ventilation. And then there were obviously a couple other case reports too. So again, ours was the first prospective randomized double-blind trial.
And definitely some of the highest quality evidence up to that point and still to this date. So
right.
I asked you to join as you are the sole pharmacist author on this study. So let myself and the audience know, like, what was your role with the study design and execution? Take us behind the scenes into kind of what you did and helped with this RCT.
Right. So I'm the pharmacy member of our hospital ILB. So just like any other ILB members, we have to making sure that the study protocols need to optimize the benefit and then minimize the harm to the patients. And so in this case, this was a placebo-controlled trial. So our ILB has to making sure that the alcohol withdrawal symptoms for patients randomized to the placebo arm, they need to get addressed too. So in this study, both the Phenobarb arm and then the placebo arm patients, they all received like a benzodiazepines, lorazepam in this case for the alcohol withdrawal. And then I also making sure that all these inclusion, exclusion criteria, drug stability, those things, they are all reasonable. And then also I also come up with like we make sure we have a plan to deal with in case if there's any like phenobarb overdose, what we have to do though. Something like, we have to come up with the instruction of like urine alkalinizations to promote the renal excretion of the phenobarb in case there's an overdose. And then, of course, if the patient develop any respiratory depression, my medical colleagues will probably intubate the patients too. And then, so secondly, and then, the pharmacy here is involved. We have to prepare the drugs like 24/7. In a pretty timely manner. We try not to delay the whole process, giving a hard time to my medical colleagues treating the alcohol withdrawal patients though. So I need to also instruct other pharmacists too, and in case when I was off too. So I come up with some very simple and easy instructions for my colleagues, and then I create a dosing sheet, make sure that the weight-based dosings go fine, because the Phenobarb injectable comes in like multiples of like 65 or 130 milligrams. So just making sure that the dosing sheet, the dosing calculation is easy for my colleagues, so it won't cause any time delay though. And then when we receive the drug order, so I make sure that, we receive a signed consent form if it's available. In this case, this study, because these patients may not be able to to proceed with the signed consent. So I also making sure that if there's no signed consent form, I'll keep track of make sure we receive the post waiver consent form later too. And then of course we make sure that patients did not meet any exclusion criteria. And then after that, then the pharmacy will randomize the patients to either the treatment arm or the placebo arm. And then we have to making sure we compound the study drug in a timely manner.
So a lot is what I just heard. You were doing a whole lot with this study.
Yeah, mainly like behind the scenes. Yeah, right. Yeah.
Yeah. Hey, right. That's how anything gets done, is by awesome behind the scenes work. And clearly that's what's, right. What's happening here. So,
right. But it's kind of fun too, actually.
100%. And, I like that you pointed out that it was 24/7 as well, because I think that's important to note, like doing this on evening and overnight shift where typically staff and things are greatly reduced. That's just a testament to the training and then, everyone's buy-in, in the institution at the time. So that's awesome.
That's correct. That's correct. So I always have sympathy for my colleagues working alone at night too. So I making sure my instructions are very easy, simple to follow, and then I will keep telling them or keep going with them, making sure that there's no any difficulties, during any randomization or preparation of the medications. Yeah.
As a night shift veteran, I can say we certainly always appreciate that. That's awesome.
Yeah.
So let's get into the trial itself, right? The trial of the week. published in March of 2013 in the Journal of Emergency Medicine. The study is entitled Phenobarbital for Acute Alcohol Withdrawal, right? A prospective, randomized, double-blind, placebo-controlled study. So, like the study said, right, it's our gold standard study design in a single center emergency department in California. And all adult patients with suspected acute alcohol withdrawal syndrome were evaluated by the enrolling kind of EM provider from January 2009 through March 2010. So, like Joe alluded to in the beginning, patients were included if they were on that institutional-based alcohol withdrawal protocol with benzodiazepine treatment. Sounds like lorazepam was probably the workhorse at that time, and patients had an anticipated need for hospital admission. So 2 key exclusion criteria: a severe hepatic impairment, which makes sense from a phenobarb perspective, and inability to get IV access. Now, patients were randomized to receive a one-time dose of phenobarbital, 10 mg per kg, or placebo. Now, 198 patients were randomized. 102 were included in the final analysis, with the primary exclusion criteria being the alcohol withdrawal was not the primary admitting diagnosis. Most patients were male in their late 40s. Around 60% required a higher level of care, right? It wasn't just a standard classic med-surg floor bed. And the primary outcome was the level of hospital admission from the ED. Where did they go when they got admitted? So, Joe, come back, highlight anything I may have missed, and then let us know what were the pertinent findings from this study.
Right. Actually, there's one more exclusion criteria, so which is like patients allergic to the medication that we provided during the study, which is like lorazepam, phenobarb, or if they have any like cross reactivity to like phenytoin or carbamazepine too. So in terms of like the primary outcome, just like what you said, the main primary outcome was the initial level of hospital admissions from the ED. In this case, it's based on the provider judgment, though. And then other outcomes our study looked at include like the use of lorazepam infusions, total amount of lorazepam used per patient, and then length of hospital stay. And then this study also examined the adverse effect that happened during this study. So the adverse effect actually were intubations, seizures, need of mechanical restraint, and bedside sitter too. And then the scoring system used in this study was called ADWA, which stands for Alcohol Withdrawal Clinical Assessment. And then the sedations, we use the sedations scale score. The ADWA score actually is an abbreviated version of the CWA score. The ADWA score widely used in our hospital around that time, and then it's a 6 parameters rather than like the 10 parameters of the CWA score. And it was like developed by our ICU doctor at that time to hopefully to develop to simplify and facilitate the whole evaluations of the alcohol withdrawal. But I just need to mention that, however, the validity and the inter-rater reliability of the ADWA score was not validated. So, again, in contrast to other, phenobarb study, ours was one of the few that was like prospective, double-blind, and placebo-controlled trials. So again, it provides some really quality evidence for the use of phenobarb. I just would like to highlight 2 things about this study. So again, and the primary outcome, which was the level of hospital admissions from the ED, was based on provider judgment, not based on any like objective criteria, like something like the alcohol withdrawal score, something like, if the patients like develop CWA score of like, let's say, severe alcohol withdrawal CWA score more than 19, or in this case, we use the ADWA score, in this case, which means ADWA score above 10, something like that. And then the other thing is, so again, the ADWA score that we use in this case, which was a abbreviated version of CWA score though, so but it has not been validated. But it was widely used around that time though. But anyway, despite the above limitation, and I still believe that overall this study provides strong evidence favoring the use of front-loading phenobarb for alcohol withdrawal.
So this was a study with patients in the emergency department, right? And emergency medicine providers were assessing patients not only for enrollment, but where they ended up getting admitted to, right? So was there any type of training or education needed prior to this study, or were these types of patients, they had no lack of experience in treating alcohol withdrawal?
Most of our ED providers, they are all pretty experienced in treating the alcohol withdrawal patients. But for this study, the most important monitoring part is because we're giving the front-loading phenobarb in addition to benzodiazepine and other sedatives too. So our providers have to make sure that they observe the mental status and then the vital signs during the study. Because, the phenobarb can cause oversedation, respiratory depression, hypotension, or bradycardia, though. So they just have to keep an eye on all these things, though. And, so otherwise they are pretty much quite familiar with treating the alcohol withdrawal patient.
So where did the idea for the 10 mg per kg phenobarb dose come from? Because even in the studies that you highlighted, it sounds like it was different than kind of the small bolus dosing scheme that we were used to seeing before this.
Right. Just prior to our study, the dose of phenobarb used, it varies from like some symptoms driven like a dose of like 130 milligram or 260 milligram, or like what I mentioned before, like some people give like 260 milligram up to like half of the dose that we give in our study. So it varies. So when we design our study, we kind of extrapolate from the usual loading dose range of phenobarb for seizures. The range actually go from 10 to 20 milligram per kilogram. And then due to like concern of the risk of like, again, oversedation or respiratory depression, especially in the setting of like concomitant sedatives. So we opt for the low end of the range. So that's how we come up with just the 10 milligram per kilogram.
So did you expect these results? Was anything surprising as you guys reviewed this data? Once the results were kind of all compiled, you were getting the manuscript ready?
In terms of the benefit, so since there was like other studies and retrospective study or case series showing the efficacy of phenobarb in terms of reducing the utilization of benzodiazepine. So I kind of expect that our study will show the similar benefit. I think what I found to be slightly surprising was the safety of this front-loading dosing. Again, we were concerned that, giving phenobarb in this case, front-loading dose of 10 milligram per kilogram would like increasing the risk of oversedation and respiratory depression. And then luckily our study, even though our study did not report any like oversedation or respiratory depression, our study did not report like any falls or mortality in either group. Also, if you look into the study, the results, the percentage of intubations in either the phenobarb group or the placebo group, they were not statistically significant different from each other. So proof that it's safe, even though I'm still a little bit surprising too. Maybe because our study may not be big enough, I guess, maybe not have enough power though. But I still think probably the risk if the patient, hasn't been exposed to the phenobarb like recently, the front loading of like 10 milligram per kilogram should be feasible and safe most of the time. Yeah.
So kind of looking at from the study, kind of where are we now? So mentioning again, these are ED patients and you work in the ICU, right? So after the results
Yes.
of this study, did you see more patients coming up to your ICU after receiving phenobarbital, or maybe more patients receiving the larger dose? Or what was the impact that you saw downstream from this study at your center?
Most providers, they are pretty comfortable with giving a front-loading phenobarb mainly for severe alcohol withdrawal patients. So usually most patients, they would start with in our hospital, the benzo that we use is lorazepam. So usually they give a lorazepam, and then if the patient still have like severe alcohol withdrawal symptoms after that, usually they will just provide like a front-loading phenobarb. The dose that they use is pretty similar to what we have in the study, and some may even go beyond that. Some of the providers, they may even go to approaching 15 milligram per kilogram too, right? And yeah, so I would say most of the providers still they're pretty comfortable, especially after our study.
So based on the evidence we have, right, this study and some of the others, what, in your opinion, what do you think phenobarbital's place in alcohol withdrawal therapy is? Do you think it's that upfront dose? Do you think it's just for the critically ill, somewhere in between? What's kind of your perspective?
My first choice is still benzodiazepine because it has more evidence for alcohol withdrawal, and then has a wider therapeutic index than phenobarb. On the other hand, I think this study and other studies shows that phenobarb dose, I think in this case, like a front-loading dose, 10 milligram per kilogram, is an effective and safe option to control, like mainly, I think it's more like a moderate or severe alcohol withdrawal patients. And then it will be a very safe option in like a ED or ICU setting. And then also it's very effective in reducing the utilization of benzodiazepines or other sedatives too.
So as we're talking, it's the 10th anniversary of this trial, right? Published in 2013, right. September. It's 2023
I'm
now. So
right.
What answers do you think we still need research wise as it relates to barbiturates and alcohol withdrawal?
So I think for me, I would like to find out, like, for patients with only like alcohol withdrawal. I think most providers are pretty comfortable providing a front-loading or even just a phenobarbital. And because, from our experience, most of our experience, shows that it's very effective in reducing the need for like benzo or other sedatives. And it's safe though in like an ICU or ED setting though. I think the questions that I have then will be like, should phenobarb actually replace the benzodiazepine as the initial therapy? Because it can quickly, calm down the patients and then, reduce the need of like more benzo. So if phenobarb is used to replace the benzodiazepine, what will be the safe and effective dose to be used in all settings, in all like alcohol withdrawal patients? So, should we just stick with like a small bolus? Because in case if they don't transfer to ICU, or maybe this is just an ICU drug or ED drug that we have to give a higher dose of 10 milligram per kilogram, and better to be monitored in the ED or ICU setting. So I think our study didn't go into details, or didn't have enough patients, and so it's not powerful enough to detect any like incidence rates of oversedations or respiratory depressions too. So I personally would like to kind of know no matter how low it is, so what's the incidence rates of oversedation and respiratory depression due to the phenobarb when it's used together with other sedatives for alcohol withdrawal. And then also, I would like to, because our study, again, the primary outcomes is looking at the level of admissions based on the provider's, decisions. So I would like to see whether, if we look at the level of admissions from ED based on some objective criteria, what will be the outcome. It will be very similar to what our study find. And so in this case, so we'll be better informed about the real efficacy of the phenobarbital. I think on the other hand, as a IRB member myself, I think, with quite a lot of evidence nowadays showing the efficacy of phenobarb, and I think a placebo-controlled trial may put the alcohol withdrawal patient to some unnecessary risk of undertreatment, though. So I think a placebo-controlled trial may not be feasible, though. And then on the other hand, also, in terms of the treatment for alcohol withdrawal, I would like to see also some high-quality study of use of other medications like ketamine, valproate to treat the alcohol withdrawal patients too.
Lots still to answer, but your study certainly did a huge job in getting the discussion started. It's crazy this was 10 years ago, but
yeah.
Joe, thank you so much for coming on, highlighting this awesome research. Thanks for all you do, and certainly appreciate you taking the time to take us a little bit behind the scenes of your study looking at phenobarbital for the use of acute alcohol withdrawal. So we appreciate you.
Thank you. Thank you very much for having me.
Another huge thanks to Joe. Please let me know your thoughts as always at PharmacyToDose, TO2Dose, or via email, PharmacyToDose@gmail.com, the website, PharmacyToDose.com. Smoke signals, whatever. Reach out. Let me know what you're thinking. Reference list with, of course, the trial of the week link, as well as a couple of those articles that that Joe mentioned, are going to be in the podcast episode description, as well as PharmacyToDose.com, the website, on that reference list. And until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast. QXMD builds mobile solutions that drive evidence-based care in clinical practice. So check out Read for easy access to research personalized for you. Calculate for over 500 easy-to-use decision support tools, and Learn to earn CME online in minutes per day. Try them today at qxmd.com/apps. Again, that is qxmd.com/apps. The Critical Care PRN optimizes drug therapy outcomes by promoting excellence and innovation in clinical pharmacy practice, research, and education. For more information, go to critprn.accp.com. Again, that is critprn.accp.com. The podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. Use of the contents and materials on the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users and patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guests and should not be interpreted to reflect the official position or policy of ACCP or the Critical Care PRN. ACCP and the Critical Care PRN disclaim any and all liability or responsibility for any direct, indirect, incidental, special, consequential, or any other damages, including without limitation, loss of profits arising out of any use of, reference to, reliance on, or inability to use the podcast, its contents, and materials.